Hello, hello everybody. Reed here. Today we're going to have a very interesting conversation on the spinal thalamic pathway. What's the spinal thalamic pathway? This is all the sensory integration, everything that you sense in your body. This is the pathway that accepts the signal and transfers it to your thalamus. Right. This is the pathway that goes from your spine to your thalamus. Right. You know, you're going to run across patients with severe pain issues, and it's best that you be able to localize the pain or anatomically sort of get a idea of exactly what's causing the pain, and then understand the nerve fibers, and then look at the nerve fibers and see what tools you have to address it. Right. So we're gonna so let me see here. So let's go ahead and look at spinal thalamic tract. Now, if you're new to my channel, please feel free to like, subscribe, and share. Mainly, my channel is more of an education channel, informational type channel. I provide a lot of detailed information about neuropsychiatry and at the molecular, what happens at the molecular biology, at the molecular level to help understand these disease processes and try to treat them. So overall, I'm a psychiatrist, and this is my trade. And I'm teaching you how the spinal thalamic tract works. So hopefully it'll be very helpful for you. So on my podcast here, you'll see additional resources. Mainly if you go to the playlist here, I have things broken down in playlists, on the different subjects. Here, this is the playlist that's going to contain all the different diagnoses and things like that, like how to treat the spinal thalamic tract. And here, like, a list of all the medications. So let me see for diagnosis. Let me see which ones we have here. Everybody, read here. So for diagnosis, okay, I have factitious disorder, somatoform disorders. I'm gonna put all the type of things, disorders on this playlist here. Let's see here, this playlist here, and then questions about medications and things like that. That's what I'm gonna have on this playlist. So you can go to the playlist to sort of see it grouped, or and then I have a lot of other interesting subjects. I'm fascinated with the subject of narcissism. I grew up in, I had unfortunately grown up between two different narcissistic family structures and two different narcissistic family systems. And so growing up in those sick environments, I sort of learned a lot about them. It certainly helps me understand psychopathology, personality disorders, violence, things like that. All the people you don't want to deal with. That's what this helps you get an understanding of what's happening. So yeah, if you're here's another interesting thing. And so the series on narcissism is called Narcissism as a Network. Right? When you're in front of that narc is just a receptacle for a receptor for a network, and you're under attack by a network. Then you see narcissistic Black family cults. If you live on the south side of Chicago, I think, listen, you have to understand this concept, because these family systems are the family systems that's bringing the death and destruction to the neighborhood. It's not everybody. No, it's these narcissistic family, Black cult families and their children who go out and murder and kill and rape and destroy everyone around. And all of us with empathy, we just sit back in silence because we don't want to be the next victim, right? Shut your mouth, right? Quiet, right? No snitching. Snitches get stitches, right? Narcissistic Black family cults ruling the south side of Chicago. That's why if you're on the south side of Chicago, you may want to think about relocating, because I think that the south side is the only access to available resources that the large races and all these things have, the large people involved in our society have to exploiting further. So you're going to see narcissism as a network, as a part of that, talking about narcissism, narcissistic families, narcissistic systems, and things like that. I have other things like diffuse traumatic brain injury, schizophrenia, negative symptoms. I'm just now finishing this series on Tupac as an actor. And so, this is part 12. And since we got part 12, we're going to produce this as a book on Tupac as an actor coming soon. So we're going to be writing a book. And also, we're going to do an animated series on Tupac as an actor. This series on Tupac and Napster is a part of my Narcissism is a Network series, right? And so this is all the things that happened to Tupac because he was surrounded by all the narcissists around him, right? So Narcissism is a Network. And so the book coming out, Tupac Was an Actor by Dr. Reed, coming around real soon. I'm going to show you how this game really works, right? So yeah, join here. I just did this one, the gender war, how narcissists have everybody living in Fortnite, right? Typically, each gender brings the other gender for their problems, but really they're dealing with narcissists. Why? Because normal men and women don't behave that way. So the whole dating scene is controlled by narcissists. And they created a gender war where they have people with empathy you can't find another person with empathy, and you certainly wouldn't get any help from another person with empathy because they sit back hiding. So I think this podcast is very helpful for you guys who want to learn more about neuropsychiatry, psychiatry, the networks around you, and things like that. Did a lot of shorts. I want to also mention here the deadly scams that's happening in Chicago nursing homes. So the South Side of Chicago is inundated with idiots and stuff. And so if you're getting health care, you have to be very careful. So look at my video on this. And so I think it'll be interesting. Now let me do this. I'm looking for so this is on the spinal thalamic tract. Okay, let me just see. Okay, let me just look at the spinal thalamic tract. Okay, let's hear the spine to the thalamus, spinal thalamus tract, right? The spine to the thalamus, right? Pain. The spinal thalamic tract carries pain, right? Temperature, crude touch, information from the body to the brain. First order neurons in the dorsal root ganglion transmit this sensory information to the spinal cord, where the axon synapse with a second order neuron. These second order neurons then cross to the opposite side of the spinal cord via the anterior white commissure. According to the contralateral thalamic tract through the brainstem to the thalamus, right? Spine, thalamus. Finally, a third order neuron in the thalamus projects this sensory information to the primary somatic sensory cortex, because this is from the somatic, right? It's the somatic sensory cortex for conscious perception, right? Now, remember, I recently had a patient who we're admitted to the hospital who was having severe pain, right? And it was very important for patients with pain to understand that you acknowledge that their pain is real, right? You acknowledge that their pain is real. Why? When you examine and ask questions about the nature of the pain, the location, and things like that, it does most of the time meet a anatomical area, or it's a reasonable description of pain. And so it's very important in these situations to sort of respect the patient's perspective and to acknowledge that their pain is real. Let me look at this one here, and let me see if I can give you a diagram here. Okay, what is the structure and function of the spinal thalamic? Remember, from the spine to the thalamus, right? And then from the thalamus to the somatosensory cortex. Once the traffic gets to the somatic sensory cortex, then you have conscious awareness of the pain or discomfort. Okay, so here, the primary somatosensory cortex, right here, that's the end point. This is an afferent. You see afferent right here, afferent. Let me see here. Afferent, meaning it's going into the nervous system. So let me just track it back from the third order, from the primary So somatic, right? Sensory cortex. Here, there's the third order to the thalamus. Okay, the thalamus is basically the relay center. The second order, this is the spine thalamic tract, right? Spinal thalamic tract. Here, then that's the second order. Then first order here in the ganglion here and the dorsal root ganglion right here. And then the fiber comes out here. Okay, so these are pain receptors or heat receptors or crude pressure receptors, right? So let me just go back there. Since we worked ourselves down, let me just work our way back up. The person we were treating was complaining of intense pain, particularly like in her neck, right? So these pain receptors were being activated, right? The afferent signal went into the system. Now, this is a relay system here. It's the ganglion. This is where a lot of the processing takes place. This ganglion is controlled primarily by norepinephrine, serotonin, and like dopamine receptors too. So the regulatory neurotransmitters are primarily norepinephrine and serotonin. Remember that, right? Because we're going to want to disrupt this ganglion to prevent signals from getting to the primary sensory cortex if we want to treat pain disorder, right? Think about this. Think about this whole thing. So let me go through again. The receptors pick up the pain, it passes, and then it's integrated into the dorsal root ganglion, right? By norepinephrine, primarily norepinephrine and serotonin. And then this dorsal root ganglion, it enters here, right? There you have the crossing over, and then the anterior cord, and on up the spine to the thalamus, spinal thalamic tract. And then the thalamus is this relay integration center system. Then the third order neuron projects up to the primary somatosensory cortex. Let me show you what this primary somatosensory cortex. Let me just show you that. Look, homunculus. Look here. This is interesting. So this, look, can I find a video with it? Can I find a video of the homunculus? There it is. Okay. Okay, let's see. Let me see if I can. Will that make it better? Let me see. Well, how do I get that? Okay, let me see if this is larger. Okay, remember in our diagram here, this somatosensory cortex. Now, this is a coronal view of the brain. It's a slice across here, and you take the face off, slice here, and then take the face off, and then you're looking into it. So here's the primary somatosensory cortex. Now, let me show you something here. Look, here it is here, right? Here it is right there, right? And so look here. The lady complained of pain in her neck right here, right? And so this signal is going to, from her neck, the pain fibers are going to be activated. It's going to go through the dorsal root ganglion, and through the dorsal root ganglion, it's going to cross over here, this anterior cord, up to the spinal thalamic tract, to the thalamus recess center, on up to the part of the homunculus that's responsible for interpreting those signals. And it's the primary sensory cortex, the homunculus, that helps you identify exactly where you're experiencing the pain or the discomfort. Now, remember phantom pain, right? Remember phantom pain? What if anything along this pathway, look up let me show you in phantom pain. In phantom pain, let's say the limb is gone, so the root is cut off. So let's say in phantom pain, when they amputate, a person have an amputation, but they still feel pain inside of the amputated limb, right? Why? Because at the end of the nerve fiber is likely scar tissue, is likely other damage to the tissue because it was an amputation, right? And that injury still activates the nerve roots and send fibers. So even though the patient may not have a leg here, because the afferent spinothalamic pathway is still activated by some reason, scar tissue, whatever, the person still feels phantom pain, right? That's that spinothalamic tract here. Let's see here. But this homunculus, let me try to. Okay, let me see here. And then I want to do the homunculus. Let me just show how this works. Blow this up some more. Yeah, look at this on the homunculus. Right. So look at this. Okay. Look, here's the trunk right here. Look, here's the trunk of the body right here. Yeah. Look at how much territory landscape is assigned to interpret the face. Right? Look at that. The face. Right? You ever get pain or discomfort in places that you're not phantom, like referred pain? You scratch here and then you get an ache in your you scratch here and then you get an ache in your neck or something like that. Yeah, this is the homunculus, and this is the layout of the primary sensory cortex in the areas that interpret the incoming signals. So that's the homunculus. Okay, so here, perception of stimulus. The first order neuron, sensory receptors in the skin detect stimuli like pain, temperature, and crude touch. The nerve endings transmit this information along the axon to first order neurons, whose cell body is located in the dorsal root ganglion. Entry into the spinal cord and moving over to the other side. Dorsal horn synapses crossing the middle line. The axon enters the spinal cord and may travel a short distance up or down in the latissimus fasciculus before synapsing with a second order neuron in the dorsal horn. Right. Crossing the midline, the axon of the second order neuron then crosses the midline of the spinal cord in the opposite side of the anterior right commissure. Right. Ascending the brainstem. Contralateral accent. So it ascends on the contralateral side, because remember, it crosses over here. Once on the opposite side, the axons ascend as part of the spinal thalamus tract. They travel through the brainstem, that is the medulla pons and brainstems, in the ventrolateral or anterolateral quadrants. Yeah, I'll show you that a little bit later. Thalamic relay. Thalamic nuclei, the second order nuclei, terminates in the ventral posterior lateral nucleus, VPL, of the thalamus. Third order neurons, they have the synapses with third order neuron, reaching the cortex. Somatosensory cortex, axons of these third order neurons project to the thalamus, out of the thalamus to the primary somatosensory cortex, right? That is the postcentral gyrus, where the sensory information is consciously perceived. So I think we got a really good look on that. Let me push this a little bit further. Let me, I'm going to ask, I'm going to try to, let me see. Explain the pharmacological treatment for pain. I'm trying to find how the signaling is disrupted in the dorsal root ganglion. And that's the basis of the treatment, right? So how do you treat these pain disorders, right? Let me show you here. Let me get off the homunculus. I'm done with the homunculus. Okay, what is this? Okay. All right, what am I trying to do now? Okay. Here's what I'm trying to do. Okay. If the signal comes in here, in order to treat a primary pain disorder, we want to decrease the afferent signals, right? So we're gonna have to target this dorsal root ganglion. Remember, the dorsal root ganglion is heavily innervated with norepinephrine serotonergic agents. So we typically give a tricyclic antidepressant. A tricyclic antidepressant targets a lot of those receptors: dopamine, norepinephrine, GABA, glutamate, serotonin. No, it doesn't do GABA. I'm sorry, it doesn't do GABA and dopamine. Sorry about that. Just norepinephrine, serotonin, histamine, alpha adrenergic receptors. The tricyclic antidepressants target all those receptors. So basically, you significantly increase the amount of neurotransmitters like norepinephrine and serotonin in this ganglion, and it disrupts the afferent signals going to the spinothalamic tract. So we want to decrease the afferent signals going into the spinal tract. If we decrease the afferent signals, then that helps decrease the intensity of the pain. So in psychiatry, we don't treat pain disorders, or we're not pain specialists, but we use our tools to help decrease the afferent signals going into the somatosensory cortex. In addition, each pain disorder has two components. There's a physical pain component that comes from damage to the nervous system or whatever created the pain disorder in the first place. Then you have a psychological component, right? And so the treatment in the antidepressants and the medications really go to aggressively treating the psychological component, right? And so let's see if I can get that here. Did I ask it the question? Okay. Pharmacological treatments of afferent pain disorders involving the dorsal root ganglion focuses on managing neuropathic pain, which arises from a lesion or disease affecting the somatosensory nervous system. Medications aimed, now, this is the first time I referred to it as disease affecting the somatosensory nervous system. I never thought about it as this cohesive system by itself. I just thought about nerve fibers just running through there, maintaining these responsibilities. Medications aim to reduce the hyperexcitability of the dorsal root ganglion nerves and modify pain signals traveling to the brain, right? That's it. Decrease the hyperactivity in the dorsal root ganglion. Okay, commonly prescribed medications. The initial approach to treating dorsal root ganglion related pain typically involves classes of medications also used for treating epilepsy or depression, which has shown effectiveness in managing pain. The medications used to treat epilepsy basically raises the threshold for action potential and slows the traffic down on all of the networks. So the medications like Depakote, things like that, it slows down the activity, the electrical activity. And I think because you're dialing things down, you're further away from that seizure threshold, right? So that's why mood stabilizers and things are helpful for, like the Depakote and things like that are helpful. And then also treatment for depressions, like I said, the tricyclic antidepressants, and because they target a full range of neurotransmitters, you can use that to sort of disrupt the neurotransmitter balance, and therefore the ganglion won't work as well, and so you'll have fewer signals. Okay, gabapentinoids. These like gabapentin, yeah, right. GABA turns everything off. Remember, GABA. Yep. Gabapentin. The anti-seizure medications calm excited neurons by mimicking the effects of the neurotransmitter GABA. So we also have to give benzodiazepines too. Gabapentin, such as Neurontin, a first-line treatment that causes side effects like drowsiness, dizziness, and peripheral swelling. Lyrica, pregabalin, also effective in improving nerve pain, but with similar side effects as gabapentin. Okay, the antidepressants. Um, yeah, so certain antidepressants are effective for neuroplastic pain by interfering with chemical processes related to pain signals in the brain and spinal cord. Tricyclic antidepressants. Examples include amitriptyline or nortriptyline. They are first line agents, but come with anticholinergic side effects and cardiac risk because it targets all of these, even acetylcholine receptors. Next, serotonergic SNRIs, drugs like duloxetine and venlafaxine are also used. Now, duloxetine targets norepinephrine and serotonin, also venlafaxine, which is also Effexor. Duloxetine is called Cymbalta, and venlafaxine is called Effexor. Both of those antidepressants target norepinephrine and serotonin. So basically, disruption of that dorsal root ganglion. Second line and adjuvant treatments. If the first line options are insufficient, others, topical agents, lidocaine, capsaicin. See, I don't like opioids. Let me get off of that. Chronic pain and opioids, let's get off of that. Emerging future pharmacological targeted delivery, monoclonal antibodies, gene therapy. I think that's all we have from there. All right, so I think that's all I have to say so now about the spinal thalamic tract. Stay tuned, folks. Tomorrow I'm going to do the cortical. I'm going to do the corticospinal tract. Let me just give you a preview of that. Like, see, from the cortex to the spine, this tract is the primary motor pathway that transmits voluntary motor commands from the cerebral cortex to the spinal cord. So later we're going to go ahead and do the corticospinal tract also. Well, I hope that's helpful for you in your studies, and please feel to. Let me see. See if I got a few questions here. Hey guys, how's it going, iHash? And Ali, how's it going, buddy? Nice to see you again, iHash. I'm doing fine. Thanks for the question, iHash. I appreciate all your questions, bro. How do physicians assess spinal thalamic function clinically? See, it's like if they're having pain, it's functioning very well. But as you can see, the pain, many patients can be, it's so extreme. It's so, all the pain is so unbearable. And it's right. It's hyperactivity. It's hyperexcitability in that nerve bundle. And so the only strategy is to disrupt the dorsal root ganglion, right? And also use GABA ergic agents like I stay away from narcotics like opiates and particularly and also benzodiazepines, but you may have to use the benzodiazepines temporarily while they're in the hospital to start settling down those networks. Ativan targets GABA. GABA turns everything off, right? So GABA has an inhibitory effect to neurons. So you give them a benzodiazepine to help them get settled, right? Sounds good. Next is Alshar AI Ali. So, hey, how's it going, Asher? Why are you just reading on AI generated things? I noticed that the AI stuff seems to explain it in everyday terms. And I have a full range of students, like from college students who are nursing students, medical students, students in the NP, postdocs, other psychiatrists, and things like that. So I have a full range. And so the AI has been very helpful in organizing everything. So I don't have to spend any time on organizing everything. And so this is a very effective tool. And then I'm using all the free resources because I was saying, I don't think I should try to make my own diagrams because there's so many free diagrams out here. So I figured I'll go ahead and do it like this. Okay. All right. And I hope that helpful for you guys. Again, like, subscribe, and share. And stay tuned to our next podcast on the cortical spinal tract. Take care, guys. Read out. Take care. Ciao. Hello, everybody. Reed here. Today, we're going to have a very interesting discussion on the cortical spinal tract. The cortical spinal tract is the tract that goes from your cortex to your spine. And when you go from your cortex to your spine, you have to be moving something. So the cortical spinal contract mainly for movement, conscious movement, right? Let's see here. Let's get down to it. So here, let me go to AI mode here. Let me clear this. Okay, explain. Explain the cortical spinal pathway. Okay, the cortical spinal pathway is the primary motor pathway, right? Controlling voluntary movements of the body and limbs. It is a descending nerve tract composed of upper motor neurons that originate in the cerebral cortex and synapse on lower motor neurons in the spinal cord. Originate in the cerebral cortex and lower motor neurons in the spinal cord. You see here. Let's look here. Descending tracts. Okay. Look, okay, motor cortex of the brain, the upper motor neuron, right? And then the lower motor neuron, then the muscle. So this must take place, what, in the anterior ganglion? So where does that take place at? This synapses. Okay, interactive 3D. Okay, I'm getting all my stuff for free. Okay, here. Okay. So here, let's primary motor cortex. Let me show you the homunculus. Homunculus. This is the homunculus here. And remember on this example here, this spinal thalamic tract, this cortical spinal tract, cortex spinal tract. This is a upper motor neuron right here. So look at the area here. So the motor area here, and then let's look at the homunculus. The motor area here, you see, is covering like the hand, the arm, the wrist, the elbow, shoulder, trunk, knee. And then here's the homunculus on the other side. Look how much it devotes to, this is primary sensory. This is afferent. I guess this is efferent right here. Efferent here. And look how much sensation it drives there. So this is where all of these bundles sort of gather together here and form this internal capsule. And then as it goes down, then it bifurcates. You have the lateral cortical spinal tract and then the anterior one. Let me show you how this is. Okay, so the primary motor cortex and internal capsule crosses over anterior cortical spinal tract, the lateral cortical spinal tract, and the anterior cortical spinal tract, two different locations here and there. And then once it goes into the ganglion, then it synapses to lower motor neurons, right? And so the the tract from the cortex to the spine is an upper motor neuron lesion here that bifurcates into the lateral cortex spine tract and the anterior cortex spine cortical spinal tract. Makes sense? Let's see here. Okay. It is a descending nerve tract composed of upper motor neurons that originate in the cerebral cortex and synapse or lower motor neurons in the spinal cord. Let me look at this one here. This is a pretty good one here. Nope, that's not it. Did I lose track of something? Okay, let me do this. And then on here, okay, let me get rid of this. And then I think let me get rid of this. Okay. And on here, this is what this was right here. Okay. And I think it's this one here. Oh, come on, man. Let me get it for free. Okay. So here it is. The homunculus comes down, crosses over to the lateral, and then over here, the anterior. Okay. So this is motor. Okay. Yep. That diagram is too small. Let me see what this one looks like. Okay, yeah, this is very interesting. I think this is a better diagram. Okay, precentral gyrus. Okay, look at all of these. Yeah, all of these here. And then it comes down. I believe this is that internal capsid here, the cerebral peduncle, all right, and then the midbrains. And then here's the medulla, the pyramids. Okay, decussation of the pyramids here. Yep. Oh, okay, look. So the lateral cortical spinal tract is huge or more. And then what's the purpose of the anterior? Okay. All right. So it comes down here. So you get upper motor neuron. Okay. Both of upper motor neuron, lateral. Okay. So here it synapses here, and then it synapses into the lower motor neuron that goes out to the actual muscle. This is a really good diagram to display this. Yeah. Okay. A good diagram. Pathway of the upper motor neuron. Originate in the cortex. The pathway begins with the upper motor neuron located in the cerebral cortex. The primary motor cortex. The majority of the fibers originate from the primary motor cortex, that is the precentral gyrus. Premotor, and somatosensory cortices. Other fibers also arise from the premotor, supplementary motor, and somatosensory cortices, which help modulate motor and sensory function. The internal capsule. The axons converge into a tight bundle known as the internal capsule, right? A deep structure within the brain, a deep structure within the cerebral hemisphere. You know, when we get CT scans or MRIs, you know, we really want to look at that area around the internal capsule to see if there's any pathology there, because it explains a lot, particularly if it's a stroke involving that area. You know, brainstem. The tract connects its descent through the brainstem. Midbrain, it passes through the cerebral peduncules. In the pons, the pathway continues through the pons, where it's broken into smaller bundles. And then in the medulla, the axons come together to form two prominent bulges on the anterior surface of the medulla called the pyramids. The axons come together so the two bird on the pyramid. Huh? Okay, great. Pyramidal discussation. At the junction of the medulla and the spinal cord, most of the fibers, that is 85 to 90% of them, cross over to the opposite side of the central nervous system. The crossing point is called the pyramidal discussation. Yep, spinal cord. After the pathway divides into two main tracts, you have the lateral corticospinals and then the anterior corticospinal tract. The fibers that cross over descend to the lateral column of the lateral spinal cord. The tract primarily controls voluntary fine motor movement and contralateral of the contralateral limbs, such as the hand and the hand. So we're talking about the primary fine motor movements. Okay, so the lateral corticospinal covers the fine motor movements. Okay, the anterior corticospinal tract, the smaller portion of the fibers do not cross over, remaining ipsilateral, descending to the anterior column of the spinal cord. It controls the voluntary movement with the paroaxial, axial muscles. That makes sense. The axial muscles don't have a side, they're in the middle. So they don't need to cross over to the other side. These fibers typically cross over at the spinal cord level just before synapsing. Okay, right? It crosses over just before, but it doesn't do it apart. Okay, so the lateral corticospinal, it crosses over. Yep. Yep, so the lateral crosses over, right? And anterior remains on the same. So the anterior is for your trunk and things like that, main structural stuff in your core, and the lateral is for the limbs, right? All right. Okay, where are we at? Okay. Let me get rid of this. Okay, I did that. Okay, yeah. Connection to lower motor neurons. Lower motor neurons are located in the anterior horn of the spinal cord, right? And project their axons out to innervate skeletal muscles in the body. The synapses with upper motor neurons allow them to carry out the voluntary motor commands initiated in the cerebral cortex. Yep. Clinical significance. Because most fibers in the cortical spinal pathway cross over in the medulla, damage to the tract results in distinct pattern of motor deficits depending on location of injury. Lesions above the pyramid discensation. Damage to the brain or higher brain stem results in weakness or paralysis to the contralateral side. So lesions. If I get a lesion here in this motor sensory, it's going to affect the other. If I get a stroke in internal capsule on this side, because the fibers turn over, these upper motor neurons are not going to give out any signals to the lower motor neurons. So this upper motor neuron is going to cause a contralateral side weakness in the muscle because this is the point it crosses over. Now remember, the anterior stays on the same side, but it's like truncal. It's like for the trunk for the trunk of your body. So this is not so, this is prominent. Let me see here. Okay. Lesion below, damage to the spinal cord causes weakness and paralysis on the same side. So a lesion here on the limb would include lower motor neurons. And so if you cut the lower motor neuron, then you're going to get like a flaccid. You cut the root, and so nothing is innervated, right? Right. So you cut the root there on the same side. So lesion below the pyramidal desiccation, damage to the spinal cord causes weakness or paralysis to the ipsilateral same side of the body. This is really important to know, particularly if you're looking at someone who's had a stroke or someone who's having side effects to medications or someone who's have some type of movement disorder. It's important to be able to look at these and see what's going on. And I think this is probably all we need to know right now on the spinal thalamic tract, guys. So if you have any other questions, please feel free to leave it in the question sections, and feel free to subscribe, like, and share. Okay, this is Reed on the spinothalamic tract. That's the okay. And if you don't mind, please feel free to like, subscribe, and share. Otherwise, this is Reed. Take care, guys. Cortical spinal tract. Ciao. Take care. Today, we're going to have a very interesting conversation on fictitious disorder. Yesterday, we went through somatoform disorder, right? Well, for the most part, a somatoform disorder is when you have real pain. Typically, you can identify an injury or a precipitating event, like a person had an injury, but the injury resolved or healed, but yet they're still feeling pain. And as somatoform disorder, is pain and discomfort in multiple parts of the body. And they actually changed the name to, I think it's somatization symptom disorder, right? One of those names. But this is next one. We're talking about fictitious disorder. Fictitious disorder is slightly different than somatoform disorder, right? Think about the name, fictitious. Fictitious. I need to use that word fictitious more. Seems like it's a pretty good word to use. Let me see, explain. Let me see, AI mode. Okay, explain. Fictitious disorder in a DSM-5. Oop, I said DSM-54. Yep, DSM-5. Okay. Factitious, not fictitious, factitious. Okay, yeah, this is not my typo is not a clinical disorder. Factitious disorder is a mental disorder where a person deliberately feigns or induces illness to take on the sick role, right? That's it. That's all you need to know. Remember, with somatoform disorder, real pain with somatoform disorder in multiple locations. And sometimes the issue may resolve, but they'll still have the pain or discomfort, or the pain may cross anatomical boundaries or things like that may be very difficult to sort of discern. So in somatoform disorder, that pain is real, but in fictitious disorder is feigned, induced illness on the sick role. A key distinction is that the deception happens without an obvious external reward, like financial gain, which would be considered malingering. You see, with that fictitious disorder, you don't know what the secondary gain is, right? But it's usually to play the sick role. It's usually for nurturing, right? These people present, and they present in more of a regressed manner, like they're children. And sometimes it seems they need someone to sit down with them and just empathize with them, just see things from their perspective and start understanding the world from their perspective. So patients with factitious disorder, they play the sick role by feigning illness because their sick role allows them to get into access with people with empathy who can sort of display empathy for them and towards them, so it's really interesting. Well, in malingering, they're lying. It's obvious what the game is. In malingering, typical situation, you see the patient comes into the emergency department with the cops in police custody, and all of a sudden they have a mental health condition, right? And so they emphasize the symptoms of their mental health condition as a way to try to get out of the legal issue. In that situation, the man tied to a gurney with the police there, And now he started to say, not saying it's not, I'm sure you have to take the symptoms as true and everything, but in that situation, I see malingering often in that situations. The histories don't match up, right? Okay, the DSM-5 distinguishes between two types of factitious disorder. Factitious disorders imposed upon the self, right? Factitious disorders imposed on another, right? On another, we see families imposing mental health conditions upon its members. The dysfunctional family units do that a lot. There's a lot of, they do that to the scapegoats within the family system, right? Usually the healthiest person within the family system usually displays the symptoms, whereas the sickest members seem to be doing just fine. Everything's cool with them. They don't have any symptoms at all. It's you, yeah, because you're the symptom bearer for the entire dysfunctional family. And so in this fictitious disorder, when they're surrounded by people who don't empathize with them, of course they come into the healthcare system looking for individuals who can empathize them. So factitious disorder imposed on the self, the targeting done by psychopathic families or psychopathic family members, they target through stalking, and covertness is the golden rule. They always stay, it seems all of them always stay covert. So when you're being attacked by, let's say, a group of sick narcissists, they all do it through third parties covertly because they never want to be exposed, right? So when they target you through third parties and individuals. And so it causes the person to have difficulties with the people in their environment, right? And that causes a lot of emotional, psychological distress. And it's hard to identify this because the psychopaths or sociopaths are around you, right? And so that's when they come into the hospital. I'm looking for more support or for support for their self-esteem, their internal, their perspective, and things like that. So this is factitious disorder imposed on the self. People who are psychologically abused come in, mistreated, or chronic PTSD. They come into the hospital and look for treatment. Right. Next is factitious disorder imposed on another. The person fakes or causes illness or injury in someone else, such as a child, to gain attention or sympathy for themselves, right? The disorder applies to this disorder applies to the perpetrator, while the victim is considered abused, right? We often see this when families trying to get disability checks or guardianships or things like that. Oh, they're imposed. They believe that they're too sick than they really are, and basically they're trying to get gains. Maybe try to get some gains or something like that for the patients. Munchausen, remember Munchausen syndrome by proxy, make the kid sick and bring the kid in for treatment and things like that. And in these situations, you see the abuser already has a diagnosis, and the abuser always have the diagnosis validated, and the abuser always have a source that they can rely to, like, oh, his doctor did this, and don't have a relationship with the doctor. You know, they set up these whole theatrical performances when they present their abuse to try to make you believe that there's a case management team, a treatment team, or someone else there who validated diagnosis, when it's just them abusing the person. Factitious disorder, these are really, really sick people. This type of sickness is, it presents itself in a way that no one can really do anything about. So, for example, when you have a person who's regressed down to, let's say, 5 or 6 years old, where they only have the defense mechanisms or the tools of a 5 or 6 years old, and they only have the cognitive powers or the capabilities of a 5 or 6 years old, when they get locked into that state and they need that constant reinforcement, the constant empathy, the constant support for their psychological functioning, they don't get that on the outside, and so they have to come into the healthcare settings in order to get these things. Okay. Both types. Identified deception. The person falsifies the physical, psychological signs or symptoms or induces injury or disease. So they falsify it or induce it. We see falsifying, here's another, if you're watching this, here's another thing they do. If they're falsifying it, if you are being impacted by this, um, um, if you go to a doctor, they'll typically call your doctor on the phone, right? So when you're not there, they'll communicate you behind your back to either threaten your doctor or try to strongly persuade them that their diagnosis is correct. If the doctor doesn't agree with it, then there's a fight. I mean, they retaliate. The aggressors, the aggressors here, they retaliate against anyone who don't support their fictitious diagnosis or the meanings of the signs and symptoms. This means that, that means that. They go through a whole process of encoding to try to make sure that you agree with all the items in their world. And if you don't, then they attack you. Okay, next, presentation of illness. The person presents themselves or another as being ill or injured or impaired. Right. These people with fictitious orders, if you're a victim of one of these, they'll go around and spread rumors about you that something's wrong with you or you're crazy. See, you see this in a fictitious disorder. The secondary game is hard to find. So it reminds me of narcissists, and how they always have to go around the people you work with and go around behind your back. They always have something to say about you, you know. And the narcs typically they make storylines about you to keep things going, and they keep revising the storylines. But these people are absolutely sick, right? But what they do is, this is weird. They cast the victim in a role, right? So that person's like this, that person like that, this person's like, he's like that, she's like that. And they have to do it 101 because they're grooming the person. You have a sick narc grooming a person, wanting you to believe that someone's crazy. And what is crazy, particularly mental health, like bipolar, schizophrenia, it's like, but when they say this something's wrong with the person, they're trying to imply that there's something ethically and morally wrong with the person. The fictitious is to present the person as if they were ill to people, right? So if you ever run around these people, or let's say a sick narc, if they're targeting you, they'll bring you around other people, right? They'll tell the other people, you're in reality A. We're going to do this, that. And by the way, so-and-so's coming, and so-and-so, this is my best friend, and so-and-so's crazy, right? And they groom them. Then when you come around thinking that these people haven't been groomed against you. And when the victim expresses themselves after that casting by the narcissist, when the victim expresses themselves, then there's more opportunities for people to find fault, to get upset, to not understand how they're responding to things. And all of this manipulative behavior is happening behind the scene with the sick narc. Presentation of illness. So that's what they do. They present you to people as if you were mentally ill, as if something was wrong with you. Now, as a victim, you think the interaction is just a little bit off. You can imagine that this person went through all that effort to go behind your back to everyone you work with and call you crazy. You wouldn't think that they would do that, but these sick people do. I mean, they do. Okay, let's see. Absence of external rewards. See, that's the thing about fictitious disorder, is the deceptive behavior is evident when there are no obvious, the deceptive behavior is evident even when there are no obvious outside incentive. The deceptive behavior is evident. Okay, right. So you see what they're doing, but in the majority of cases, you can't find the incentive, right? So I had a sick narc always talking about me. I mean, constantly behind my back at work. But when he talks to the people, they can't understand what his incentive is, right? Because he presents as if we're friends and things like that, if he really knows me and everything. But pss, 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 right? This is the best example of that type of behavior that I can describe. Fictitious type. You have to be really sick in order. I see a combination. This person has a combination of narcissistic and fictitious, narcissistic with fictitious compliments. Sick person. Not explained by another disorder. Yeah. Okay, great. Not like if they were like psychosis or something like that, or bipolar thing, or if they were just messing up, if they were just having a bad day or week, then yeah. But yeah, so this is a fictitious or disorder. Let me see. How. Okay, got me. I can't type and look at the same time. How are fictitious disorders or the somatoform? So how are fictitious disorders, somatoform disorders similar and different? Okay, factitious disorders and somatoform symptoms and related disorders, the current term for what's previously known as somatoform disorder, both involve significant focus on physical symptoms that are not fully explained by a general medical condition, right? However, the crucial difference lies in the patient's conscious intent regarding their symptoms. That's it. It's the conscious intent. Similarities. Both involve presentation of physical symptoms that medical professionals may struggle to explain or attribute to a clear organic cause. Number two, both groups of patients may organize their lives around seeking medical attention and services, often presenting to healthcare settings repeatedly. Third, both factitious disorder and somatoform disorders are considered psychological conditions with significant emotional distress. So, motivation motivation for behavior, the motivation is internal, psychological, and assumes the sick role. The patient seeks attention, sympathy, and care. In somatoform, the motivation is unconscious and may not assume a sick role, right? Because remember, with a somatoform disorder, they can internalize the psychological pain and distress, and it appears as real pain and discomfort. So the somatic symptoms, this is unconscious, right? Yeah, I think that's the difference between the two. I think that's all I need to do for now. We're at the 18-minute mark. I'll end up there. So this is my talk on factitious. I have to change. I can spell the word. I spelled factitious wrong on there. So if you have any other questions and everything, feel free to like, subscribe, and share. And otherwise, I'll talk to you guys later. Read out. Take care, guys.